Welcome to the Healthcare Unfiltered Express, where I conduct short video interviews packed with relevant and timely information that you cannot miss. So sit back and enjoy the show. Dr. Andrea Apolo, welcome back to Healthcare Unfiltered. Although we're on the Express version today, which is, we live in a short attention span, my friend.
That's true. Thanks for having me back.
Thank you. And I know how busy you are, so really appreciate it. And I've challenged you today that we're going to try to simplify how we treat bladder cancer. And I'm going to start with early stage muscle invasive bladder cancer. How are we approaching patients with this disease today?
Okay, so for muscle invasive bladder cancer, the main treatment for it is surgery. You do a radical cystectomy and lymph node dissection for those patients. And then you do a bladder reconstruction, so some kind of ileoconduit urinary diversion. But in terms of improving outcomes, even by doing that, about 50% of patients will have their cancer come back. So there's been a lot of interest in doing neoadjuvant and adjuvant therapy. So right now we have new data from the Niagara study that shows that platinum-based chemotherapy, cisplatin-based chemotherapy has been the backbone of neoadjuvant therapy for bladder cancer. So we give combination platinum-based chemotherapy in the neoadjuvant setting. Now we're in the Niagara study, they added durvalumab in the neoadjuvant setting in combination with cisplatin and also in the adjuvant setting. So the study showed an improvement in event-free survival and overall survival for patients with muscle invasive disease. So that is something that we're giving now in the neoadjuvant setting. And if they are not platinum eligible or they did not receive neoadjuvant therapy because they refused or because they were maybe not a T2 and then they were upstaged at surgery, they had the surgery and then the pathology showed that they had high-risk disease, there is the option also for giving adjuvant immunotherapy. And we have two trials, the Checkmate 274, which is adjuvant nivolumab in patients with high-risk muscle invasive disease that has shown a doubling of the disease-free survival. And my own study, the Ambassador study with adjuvant pembrolizumab that again has also shown a doubling of the disease-free survival in those patients. So those are treatment options for patients with muscle invasive disease. So neoadjuvant, you give Gemcis plus Durva, do the surgery, and then after the surgery, you give adjuvant durvalumab. If you don't get neoadjuvant therapy and you have high-risk disease in the adjuvant setting, you could always give chemotherapy, but immunotherapy is also an option too, and that's with nivolumab or with pembrolizumab. So in essence, that's muscle invasive disease.
Are we no longer giving dose-dense MVAC in the neoadjuvant setting?
We are. So dose-dense MVAC is an option, but the Niagara study used gemcitabine and cisplatin as a treatment arm. So we don't know the data of what IO plus dose-dense MVAC would be, and there are some smaller studies that are being done kind of asking that question, and there is safety for doing that, but we don't have long-term overall survival data for doing it that way. And so I have kind of moved toward incorporating the IO in the earlier setting as opposed to doing the dose-dense MVAC. Even though that is an option if IO is not available or durvalumab is not available, then I think using dose-dense MVAC is an option. And the VESPER study compared the dose-dense MVAC plus the Gemcis with the 6 cycles and showed that the patients did really well with 6 cycles of dose-dense MVAC versus 4 cycles of Gemcis. But honestly, I think both are options if IO is not available. Yes.
Before I move on to metastatic disease, Andrea, do I need chemotherapy in the neoadjuvant setting? Anybody looking at just IO, cystectomy, and then IO?
Yeah. So cystectomy followed by IO, you mean in the adjuvant setting?
Yeah, I mean, you said we use Gemcis Durva, followed by cystectomy, followed by Durva. I'm questioning, do I need the Gemcis?
Do you need the Gemcis? Right now, yes, because that's the data that we have available, although there are many trials that are kind of now looking at moving the antibody drug conjugates plus the IO together in the perioperative space. IO by itself is active, but it's the pathologic response rates are just lower than when you give it in combination with chemotherapy. And the first line metastatic studies did not show an improvement of platinum-based chemotherapy. So it's not something that we give by itself in the neoadjuvant setting.
Let's move on to metastatic disease.
Okay, so for metastatic disease, we have the new treatment of enfortumab vedotin plus pembrolizumab. That is based on the EV302 data, and that actually has improved overall survival for patients with metastatic disease by doubling it. So it went from 16 months to 32 months with enfortumab vedotin plus pembrolizumab when you compared it to cisplatin-based chemotherapy. So that is the new standard of care. And if the patient has not received platinum in the perioperative setting, then you can give them platinum in the second line setting, and that's cisplatin or carboplatinum. So you could do cisgem, you could do docens MBAC, or you could do gem carbo. Now, if the patient has an FGFR3 alteration, then they can get erdafitinib also as a second line option. If they have HER2 3+, the FDA has approved trastuzumab deruxtecan or TDXD for patients that are HER2 3+ positive. So that's a treatment option too for patients. And of course, second line, you have the option of docetaxel, paclitaxel. There's sacituzumab govitecan also has been used as a second line option for many years. However, the drug was withdrawn from approval by the FDA because the TROPiCS-04 study was negative. It did not improve overall survival compared to paclitaxel or docetaxel, but the drug is active. So I think it was because a lot of the patients did not get growth factor support. So I still give SG because it's a good treatment option that doesn't cause neuropathy, and a lot of patients have neuropathy because they've gotten enfortumab vedotin EV, which causes neuropathy. They've gotten cisplatin, which causes neuropathy. So at this point, you get to this third line setting where a lot of patients have really bad neuropathy. And if they don't have FGFR3 alterations, or they do and they've already received erdafitinib, or they don't have HER2 positivity of their tumor, then there really are limited treatment options, besides, of course, a clinical trial, which should always be considered. But standard of care, there's not a lot of options. So I still do give SG to those patients with responses in many patients.
But your first line therapy today, you do sequencing to check for the FGFR, and then you check the HER2/3, and if these are negative, is that when you use EV or?
No, EV is used first. That's the first line treatment. And actually the FDA indication for erdafitinib is they must have gotten IO first. So you use it after IO in the metastatic setting.
Got it. And then how often do you see FGFR3 in bladder cancer?
About 15 to 20% of the times in the metastatic setting. It's more common in the non-muscle invasive setting, but in the metastatic setting, it's about 15 to 20%.
Maintenance therapy in metastatic disease, we heard a lot about over the past couple of years. Where does that stand, and how does it really affect your treatment decision?
So that's a great question. We used to give for decades platinum-based chemotherapy, and then we had the study of Javelin Bladder 100, which was maintenance avelumab to the patients that responded to platinum-based chemotherapy by either having a complete response, a partial response, or stable disease. Those patients went on to receive avelumab, and there was an improvement in overall survival with those patients compared to the ones that did not. But now that the patients are getting IO in the front line with enfortumab vedotin and pembrolizumab, there really is no data that giving additional IO after they progress improves outcome. Clinical trials are being done to ask this question, whether retreating with IO provides some kind of clinical efficacy in these patients. But right now, if you're giving platinum in the second line setting after they've gotten EV plus Pembro, there really is no role for maintenance IO with avelumab at that point.
So pretty much nobody is using avelumab at this point, right? I mean, is it fair to say it's very unusual to use maintenance avelumab today?
That is correct, yes, unless EV is not available. Yeah.
So
Or there's a contraindication to using EV on patients that have uncontrolled glucose, they have some kind of skin condition. It's a very rare instance where EV cannot be given, but if it's not available, then you can potentially do the platinum followed by the IO. And then we also have the cisplatin, gemcis, and nivo data from the Checkmate 901 study that showed that there was a survival benefit compared to just cisplatin based chemotherapy, gemcis by itself in the first line setting that is FDA approved for metastatic bladder cancer. But of course, now that EV plus Pembro is available, there really isn't opportunity to use that combination because everyone's already gotten IO by the time in the first line setting. So there, gemcis nivo is really not being used, at least in the United States, but I do hear that it's being used in places outside of the United States where EV is not yet available.
this is really amazing. I already feel I know everything I need to know about muscle-invasive bladder cancer in early stage and metastatic disease. Dr. Andrea Apolo, thank you so much for visiting with me.
My pleasure. Thanks for having me.
Thank you for listening to this edition of the Healthcare Unfiltered Express. Until next time, take care.